come back to say I love the lunchtime ready option. We avoid the evening fatigue, as it was with the webinar fatigue, and it just allows people to watch it back. So I'm very, very pleased that sort of worked out for many so far. So hopefully, Lindsay, if you're on, you could just continue to admit people in. That'll be useful for me. And what we'll do, we'll just get the slide deck open, if that's all right. So in terms of context then, what we've got today and lined up for you is a lunchtime ready contraception webinar. Yeah, it's all about women's health for the next hour. So that is critical and crucial for us, and how community pharmacy helps support the women's health agenda. And in particular for us, it's about the community pharmacy oral contraception service. And the idea of the webinar, we'll cover the agenda, is to allow us a chance for our guest speaker, which I'll introduce in just a second, is to give us a bit of a flavour with that expert line, give us a bit of confidence in the sort of pharmacies that we now have registered. And I'm going to start off with that good news first, if I may. Which is we've now got almost all of our community pharmacies across Lancashire and South Cumbria, and Sarah will be happy with this one, and Dr. Ewa, 357 community pharmacies signed up. Literally only a handful left. So this webinar in particular, and at this time, is going to be really, really crucial for us. So on to the next slide then. So we've got obviously myself, the Chief Exec, Community Pharmacy Lang South Cumbria. Hello and welcome to everyone. And we also have our guest speaker, Dr. Ewa Craven today, who's the LSCICB lead for women's health, a lead GP, a menopause specialist. And we also have Sarah, which we'll hand over just shortly. She always wanted to come on live. She said, don't put my snapshot on, I want to come on live. I said, no problem. So we've got the Women's Health Delivery Manager, Sarah, who's on as well. So if you don't mind, I'll just cover off a brief outline of the agenda. So we just got more people jumping in. Oh, so a bit of a go slow. Right, so we've got the agenda there. So a quick introduction, natural housekeeping. We have set it so anybody who's coming in will actually be muted as they come in. We probably expect some pharmacists and individual colleagues perhaps to break off as they need because it's lunchtime. And they might actually still be supporting patients. Again, that's the advantage of this and the advantage of the recording. But we'll do some quick introduction and housekeeping, then we'll go on to the overview. We'll go straight to Sarah for an overview of the Women's Health Programme, and then we'll cover off the oral contraception, the main event, if you like, with Dr. Ewa Craven. And best of all, we'll have an Ask the Expert session, which I will chair to allow you all to ask any questions you may have around oral contraception, progesterone combined, whatever that may be, and initiation and repeat supplies. And then at the very end, just before we close, just as a reminder, I will just nicely cover off the adjustments that are due to come into force on the 29th of October around emergency contraception and what that means for our contractors, our teams across Lancashire and South Cumbria. And we've still got more individuals joining us. So anybody who has just come in and joining us, hello and welcome. We are kickstarting. This will be recorded, so you'll be able to watch it back at the end as well. Right, on that note then, we'll continue to admit even more people in. We'll hand over to Sarah, if that's all right. There we go. Your first slide is up. Over to yourself. Thank you.
Just a brief introduction, really. So myself and Dr. Craven are both part of the Women's Health team as it stands. Obviously, we know there's lots of changes in the ICB. The programme's been around for just about nearly 2 years now, and it's informed because of the national strategy. So in 2022, Women's Health Strategy was launched, and then there was also the national ask to set up women's health hubs. Now, it's probably no surprises, and Lancashire South Cumbria, we're still I've got a lot of groundwork to do. So we are slightly a bit behind as a full disclaimer, but we are still definitely trying to work ahead as a team as it stands, which inevitably we don't know what the future holds within the ICB. So interesting times, definitely. I probably should have took control of slides, but if not, Mubasha, will you just move on to the next one for me. Just a real glimpse of what we're trying to do from the programme and what our objectives are that we've set internally. So trying to align with the women's health strategy, with the core spec requirements from the national team, but also now making adjustments with the 10-year plan as well. That we've got some key objectives from the ICB, what we're trying to deliver, keeping all them in mind. So we want to enhance preventative care. Again, not been as typical in the NHS. We're very much treatment focused, but really taking that public health kind of angle and that population health viewpoint. Definitely more aligned with the 10-year plan. Improve access to high quality women's healthcare. Now, this is something we know of. We know none of our acute trust providers, for instance, provide menopause care. As specialists, they do get commission to do it, but they're not specialists. We've got no community gynecology services, and we've got quite fragmentation around sexual health. So particularly around contraception in this case, we've definitely got some fragmentation, which is why it's so welcome to have community pharmacy in this world as well, because the women have got an extra choice and resource, which is absolutely the right thing to do. Reducing health inequalities is a real big drive for us within the ICB, and it will be part of our core strategy going forward. We want equity of care, not necessarily equality, but we really need to make sure we're targeting every single woman. And we do recognise that not every woman will use all the services in place, sexual health or primary care, even not everyone's got a GP, and having community pharmacy in that mix as well, I think will absolutely help with that health inequalities around contraception. And delivering right care at the right time. I think that's really key. We know women do take a lot of control and independence over their own healthcare, but having that access to right information at the right time when they come to you for support. And often community pharmacy, you are the actual first point of contact before they even recognise potentially that there's some issues there. You really are a real key stakeholder within the women's health care. We're very much focusing on community as one of our main targets. So trying to really encourage and employ many of the voluntary sector, pharmacy, libraries, etc., to be part of that empowerment for women, so they get the right information, the right education, so they do go to primary care at the right place, right time, and not end up in a worse state for that lack of early intervention. So that's one of our key focuses of bringing in that care into the community earlier in the pathway and accessing women who don't even know they need treatment. Next slide. Just a real quick overview. So women's health, contraception is one of our key issues, but as you can see, we're doing a heck of a lot more. So pharmacy, you are going to be our key protocols for many of this, but particularly around contraception, around our contraceptive pills, and even going forward, we know there is ambition. Sorry, my best to say, not me, don't blame the messenger, but I know there is a real key drive for having implants, so the long-acting reversible contraception as a deliverable in pharmacy land eventually in the long-term future. I think there is a massive shift of this kind of activity going into community pharmacy as well. I don't think everything should just be one place. Women should have a choice, and that is what the key focus is, that women have choice, get access and treatment where they can get it the most appropriate and available to them. So anyone got any other passions with any of them other topics, please let me know and I'll be happy to bring you into other conversations, but I won't bore you with anything beyond contraception. Next slide, Mabasha. As you can see, Women's Health Team, we actually currently sit in the maternity directorate, which it may not be like that going forward with the restructuring. We do know it's staying women's health overall within the ICB, so we've got a very much a passion around women's health, and there is going to be a drive to improve the whole elements of women's health. So that's from birth to death, and it's also at all access points as well. So it's full ICS working together, full pathways, not just acute trusts or just a primary care. It's everybody working together to get that women's health care in a much better state. the end goal is that we have a much better, healthy life expectancy for our women. We get rid of this gender gap and women get access to care they should have. We shouldn't have women having poor menopause, poor periods, and should have a choice in looking after their own bodies. So this is what our key aim is. And as you can see, we actually interface with many different specialities, not just ICB, local authority and beyond, and community pharmacy is definitely one of our key people within that to make this work. And we can't do it individually as a director on its own right. So you are absolutely essential as part of the mix. Next slide. I think I'm pretty much towards the end. It was just more, yeah. So it's just to say that you're absolutely invaluable in this workspace. We are there to support and recognise as much as we can do. And hopefully you'll find ever a wealth of knowledge and support, and anything on wider conversations, feel free to either email or send me a message and we'll pick up. No problem at all.
That is fantastic, Sarah, and much appreciated. And great to hear, such an influence with community pharmacy, having impact and accessible care, which is what we offer, and also for our contractors and their teams to come forward, really change that mindset. You mentioned LARCs as well. That is on the NHS 10-year plan. We will be reviewing and looking at that. We have got a couple of pilots across the north that are already trialing. So it's music to our ears for the future provision. I am now going to stop sharing, if that's all right, so we can have a bit of an open conversation. And allow and hand over to Dr. Craven, if we can, just to start give us a bit of a flavour in terms of building some confidence for our community pharmacists and our sort of techs in the future around initiation and repeat supplies of oral contraception. Over to yourself.
Yeah. I said, yeah, unmuted now. Thank you so much, Mubashir, for inviting us. As Sarah said, it's really important that we work together, and obviously you are often first point of contact for people coming to ask about contraception, and therefore I think we've got a lot of power, and it'll be really important that we work together and we work in a very informed way and in keeping with the guidelines, and also understand how we support each other between the pharmacy and primary care. I work in primary care, so certain things, and also sexual health services. So women have all these different options they can explore. I think I decided today I will just talk. I've got some deck of slides, which I didn't send. I prepared them previously, but I could send them to you, Mubashir, for after, and you could maybe distribute them just to reinforce what was said. I think it might be easier just to have a conversation. Is that okay with everyone? Yeah.
Yeah, that's fantastic. Yeah, just
let's go with it. So I think the first, I'm a trainer as well for FSRH, Faculty of Sexual Reproductive Health. So I think I know I've been working with advising women on contraception for a very long time. I've been in Stockholm, based in Stockholm for 18 years, and previously worked in gynae. So I have quite a lot of experience and have encountered very many different situations. So I think the first and foremost, what's really important with contraception advice and contraception prescribing is taking a really careful history. As we know, contraception contains hormones, and hormones are extremely powerful molecules which can actually change the woman's life to a lot better, but can also make it a nightmare, and as a result can put somebody off contraception altogether. So it's sort of like read carefully here, take a careful history, and when I mean history, I mean things asking about things like when did the period start, how do they behave, how do they affect day-to-day life of a given person. And I'm not saying that you'll be diagnosing, somebody, oh, you may have PCOS, you may have this, but sometimes people may come to you and say, oh, I've got PCOS, or I've been told I've got PCOS, or I've got endometriosis, but I need contraception. And then, you know, obviously you could either say, well, go back to your GP, because this is a bit more specific or a bit more complicated. You may say, you know, especially if you've got interest in this area, you may say, well, let's just try to work out what would be good for you to use here. And with such a vast choice now of what we've got with regards to contraception, I'm always saying to patients, there will be something which will suit you. You know, don't worry, we will find it. And it doesn't always have to be the first one we try. The first, you know, that's why the review process incorporated in prescribing contraception is really important. And usually the review is recommended after 3 months of use, just to sort of fresh out those initial problems, concerns. And I don't know how it works for you guys, whether you've got that built in your contract, that you're able to do that review, but it is really, really important. So I was thinking how to structure this best. Maybe, you know, we know we've got progesterone only contraceptives and we've got combined contraceptives. So they are like 2 main divisions. And each of these divisions, then we've got subdivisions. So with your progesterone only, obviously you'll be looking at different generations of progestogens, which are in progesterone only pills. And the main ones really, which are used at the moment, they are desogestrel, which is names like Cerazette, for example. And that's everyday pill, or drospirenone. And drospirenone is a little bit of a new kid on the block. Drospirenone was combined with estrogen in preparations, but now we're lucky, I would say, to have this as a separate product, as drospirenone is a very nice progestogen for people who experience potentially metabolic, so, you know, perhaps slightly heavier weight, or have problems with the blood pressure, or have other concerns of that nature, but also it's quite good for mood regulation. So that comes to place when somebody may report a real decline in mood before their period. So when we're asking about the periods, it's important to ask about when, how long, how painful, how they affecting, or also if they're regular or not regular. But also how the mood, how person feels before the period, because some people can feel very, very extreme just before the periods. And then things like drospirenone, which comes under the name of Slind, as a single product, it's really, really useful. And interesting thing with that one is that unlike other progesterone only preparations, this one has got 24 active pills, and then it has got 4 inactive ones. There is a choice here. It just depends what you're trying to achieve, or if a woman wants to achieve. And the license indication is always 24 and 4 inactives, and that's how the packet of a pill is built. So you've got those placebo, different color pills in it, but they can use it in some situations when they really don't want to have a period, or the period brings with it outbreak of acne, for example, or other unpleasant symptoms. Then they can use it quite safely back to back. So so that's progesterone side of things, progesterone only. And then much bigger choice comes in combined preparations, where you've got estrogen and progesterone put together. So again, they are ones which are probably the cheapest now, which contain more androgenic, we call it, progesterone. So yes, so getting back to progestogens, some of them will have a higher androgenic effect, which means they sort of slightly more similar structure-wise to androgens. So you probably will be wary with them if somebody presents to you with acne or excessive hair, already having these problems. But they are very good for bleed control. So it's that kind of balance. So when there is representation which could resemble almost like polycystic ovarian syndrome, when people get acne and excessive hair, you wouldn't want to be giving them progestogens which are more androgenic. So the ones like medroxyprogesterone or norepinephrine, they are very, very androgenic progestogens, and may increase acne and may increase excess hair. So for people like that, for example, the much better ones will be, again, drospirenone, because drospirenone will be helping with this, or things like Dinogest, for example, combined like it is in a pill called Clara, or I think they are the main two ones which are out there on the market. Now, I know that you're restricted by pricings as well. I mean, I spoke to colleagues who are working in practices now who came from the pharmacy, community pharmacy, and I know that there is a lot of restriction there. And I know that some of the pills which are newer or a bit more sophisticated compound-wise, they will be more expensive. And I just don't know how this works within your systems and how realistic it is that you can be reaching out for them. But I think having an awareness of that is really important. Another thing is, when you're thinking of a person, for example, with a heavy menstruation, the important thing here is to try to help them to reduce the bleeding. And you could use the older regime pills like 21/7, which examples like microgynon or Yasmin, but it's important, or Celeste from older ones, but it is important to consider using them back to back. And using pill back to back, that means that you use active pills. So you use 21, and without having 7 days break, you can carry on using the pill. So what the pill does, the pill just will suppress the ovulation, and it will thin the lining of the uterus. Therefore, it will make bleeding less and less and less. When people use those continuous regimes of pills, at first they may get slight, in the first 3 months they may get some breakthrough bleeding, but after that everything sort of normalizes, and they do become amenorrheic. But because they're getting enough progesterone on board, that amenorrhea is not an unsafe amenorrhea according to what we know currently. That use of pill back to back is very much accepted by FSRH, Faculty of Sexual and Reproductive Health, but also by Family Planning Association. And it's been actually published before pandemic, because I think in a GP land, a lot of colleagues were worried about this way of using the preparations, but it is absolutely safe. The pill-free break is sort of a historical thing almost. It started when pill was first introduced in 1960s, and it was very high doses of hormones, and it was thought that might be unsafe to use it all the time. And also women like to have this sort of period. The period on the pill is not a real period, it's just a withdrawal bleed, but it sort of gave women reassurance that they're not pregnant. Whereas now we know that if somebody uses pill really regularly, that is very important. I think from a pharmacy side of things, it's just checking that compliance is super important, because for a young woman, if she misses one pill, there is a big risk of her getting pregnant, and that's even one missed pill. So and a very important thing is giving that missed pill advice, and what people need to do. And we could maybe discuss it in questions and answers. I don't know how aware everybody is here of that, so I don't want to say something which is perhaps obvious, but it is important part of a review, initiation, and then review. We could maybe, another thing I wanted to mention with regards to combined pill, it's more sophisticated pills, which are quadriphasic pills, and there's not many of them, but one of the examples is Clara. And Clara is the pill which is slightly different doses for different parts of the cycle. And that Clara it's really good for controlling heavy bleeding and people who potentially have endometriosis. Clara does suppress the lining very well, and it does help with the pain significantly, with the period pain. And it should certainly it's a good one to consider, and usually well tolerated. It also contains body identical estrogen, a bit like in HRT, same as estrogen is in HRT, which is estradiol. there are not many pills with estradiol. Most of them contain synthetic estrogen, which is called a phenoestradiol. And we know that estradiol is being body identical. It's that a little bit better for metabolism, and it's just more similar to what our own estrogen is. How should ideal pill initiation consultation look like? I mean, careful, like I said, very careful history. Depends on the age of a person as well. So making sure we have a competency to understand our information is there, and sort of where younger girls, it is important to always encourage them, to get their carers or parents involved in the fact that they trying to make this decision. But at the end of the day, if they can't do that, I think just a little bit around safeguarding and just making sure that they are in a safe place when they're presenting to you, because obviously we know all about child sexual exploitation, and we heard from the workshops, various workshops on this, that sometimes they do present to pharmacy recurrently for a morning after pill or treatment for urine infections. Which is, if it's a recurrent presentation, or you get somebody like that coming for contraception, there is always worth to really look sort of behind that person a little bit, what may be going there in her life. But generally, if a young person and you feel you had this discussion, you feel they can understand the information you're giving them, we shouldn't be refusing contraception, because obviously that puts them at risk of unwanted pregnancy, which has got much more serious implications. With that first initiation consultation, it's important from the onset to probably go over which things which they may be worried about, or maybe their parents mentioned to them, like risk of cancer. And a lot of young girls come and are worried about breast cancer. I mean, the worry about breast cancer, risk of breast cancer in the young people is very low. They already have very high estrogens anyway. So what we're doing with a pill, we are just slightly sort of almost suppressing their ovary and giving them external estrogen. That's how it works. So we're not necessarily increasing their overall level of estrogen. So in a young person, I'm not really too concerned about that risk. I think where you need to be careful with estrogen, it's situations when somebody's coming with really severe unilateral migraine with aura. That is your warning sign for estrogen-only contraception, but person like with this presentation will be safer with a progesterone only, especially drospirenone should work quite well in that situation. Also asking them what they would like, what they worry about, so they may say, well, I also got really bad acne. So again, if somebody, say a 14-year-old comes and they, want the pill, but they are already, you can see on the face, they have lots of spots. You probably don't want to be giving them pill with a medroxy or norepinephrine, because for sure this will make it worse, and especially will make it worse when they do pill-free break. That's when they get a big outcrop and they're not gonna like you. We've had situations like that when people came to the surgery and they were using 100 creams for acne over the counter, and some from us, and nobody changed their pill, and they were very upset why the pill wasn't changed, because once they changed the pill, for example, to Yasmin from Microgynon, they had an amazing result. And drospirenone in Yasmin, because drospirenone is also in Yasmin, cleared the acne beautifully, and they were much, much happier. So it's sort of consider the person as a whole and their circumstances and what else they are coming with. And I know it's really hard in a short time. I don't know how long pharmacists get to do these consultations, but I'm sure it's not a very long time, but it's just good to, especially on initiation, to consider all these factors. Another one is smoking. So just really careful with some young people who are quite heavy, can be quite heavy already, quite heavy smokers, and just understanding that and the risk of oral estrogen, an increased risk of clots potentially with these. Always warning them about clots, so always making sure that they know that if they immobile for any period of time, like even on a long haul flight, or dehydrated, or being in a heat for a long time, and maybe just lying on the beach and not doing very much, but they are little bit more at risk. And if they get swollen leg, they need to sort of think about it and worry about it, get it checked. Because it could be a sign of DVT related to oral estrogen. With initiation as well, so we talked about considering who they gonna be having relationship with and why they want the pill. So that's a big one. Considering their menstrual history, considering their other concerns, and also considering what they used before, because they may come and they said, oh, I used this and I used that, and that really made me feel bad. So just thinking what was in that or the other preparation which didn't kind of gel with them, and probably trying not to give them something which just has got very similar stuff in it. Being considerate and listening. I think a lot of it's about listening to the history. Patients usually tend to tell us quite a lot if we have time to listen to what they saying. And also giving that choice about continuous versus interrupted regime. So pill-free break, without pill-free break. A lot of women still come quite guilty when they say, oh, I took my pill back to back for the last 2 months, and nothing bad will happen. Nothing at all, because in fact, you can take it back to back forever. You'll be absolutely fine. So that is fine, and that's a good way of controlling periods, because I've seen some coming for norepinephrine when they're on the pill and they want norepinephrine to stop the periods. So obviously, so giving them that advice. If you're going on holiday, you're having exams, or something else is going on in life, going on a swimming trip, you can take it back to back absolutely fine, yeah? Or you can take it back to back, say, for longer time as well. So considering patients' wishes and lifestyle. And then obviously with a choice of whether progesterone only or estrogen, it's thinking about the weight. And obviously obesity is a big problem. BMI over 30, certainly a caution. BMI over 35, I probably wouldn't be going for oral estrogen at all. So considering, more these people should be offered progesterone rather than estrogen. Somebody, or somebody with a history, even they coming for a pill, history of TOP, termination, perhaps they've already been on the pill and inconsistent use. So again, a lot of people with ADHD, they can have sort of a bit more scatty memory. So there is a lot of young people, as we know now, it's quite a big problem. More people being diagnosed, and the memory can be it can be difficult for them to remember the pill. And obviously, like we said, one pill missed, pregnancy. So maybe signposting them towards long-acting reversible contraceptives and reassuring. And I think it's important that from pharmacy, where to signpost for these things. So perhaps in each area, sort of knowing which surgery provides, they called LARC methods. So that's the Nexplanon. There is nothing, I don't know how it works in a pharmacy, whether you guys fit Nexplanons or not, whether any pharmacists are trained to do that. But if not, then obviously sexual health services and some GP practices do fit Nexplanons and do fit coils. So I would really strongly recommend that we bear that in mind, and we do consider long-acting reversible contraceptives. They are recommended by NICE guidelines. It's more cost-effective, but there is also huge patient convenience, and we can use them for young patients. Just remembering that, if pill isn't suitable, young people, even if they not had pregnancy, they can be signposted for a coil. So it was, I think, there was an opinion that you have to be pregnant before you have a coil, and actually that's not true. And coil is is a very good option for a lot of young people. So again, just remembering that signpost too. Trying to think. So initiation. So I think another thing on initiation is because you'll be asking about some sexual history potentially, and if you think that somebody is at risk of STIs, again, signposting them to GUM to get tested. It's better that they stay healthy and have regular tests, and if they start with a new partner, to have a test, and also reminding them that if they use contraception, people who use combined hormonal contraception, they still exposed to sexually transmitted diseases. So condoms are still a useful thing to remember about if they want to avoid that. And so that's because sometimes get, oh, I thought this protects me. Well, no, it doesn't protect against STI. So that, and then careful medical history, we said that, menstrual history, a little bit of lifestyle history, and then yes, so then once you issue the pill, then starting obviously day 1 or 2 for the best for being effective straight away. If they start any time of the cycle, it will take a week for this to be effective. So probably ideally waiting to keep it all regular and in pattern, waiting for day 1 or 2, but it depends on a circumstance a little bit. And then using it daily, very important for a combined pill to be used at just exactly the same time of the day. With progesterone only pill, we've got a bit of leeway. We've got those 12 hours with the progesterone. But generally, it is much better for everybody and for how body hormones work to take it at the same time. So we're trying to encourage, phone alarms and things like that, which people can use to remind them about it. And then we do missed pill advice. I think it's good to give it, and when you initiate, so if there was a missed pill, so take one. It depends how many missed pills, and I think the missed pill advice is quite well stated on every leaflet of the pill, so you could either repeat it or signpost them to the leaflets, but there's very important information to give them. The missed pill advice, and then I think moving on from there is the review. So like I said, I'm not sure how you do it, whether you do that review at 3 months. Do you bring them back at 3 months? And then again, checking how they got on, what worked well, what didn't, what problems did they have. You may get some people coming back saying the pill kills their libido. Well, it is possible. The obviously affects own hormones. It affects one of the globulins in the body called sex hormone binding globulin, which increases with oral contraception. So more hormones get sort of like bound in the bloodstream, so not active. So it can actually affect amount of testosterone a woman has. So it is not a myth when they say that. And again, I would say just trying different type of pill and see if something, different progesterone will work better for them. And in fact, with them, you may want to consider a bit more androgenic one, like medroxy or norephisterone, because they may work better with that respect. So, and also on a review, it's making sure about bleeding. So what happens with their bleeding pattern? If they're happy, not happy, how did their skin behave? How did they get headaches? And another common thing is that people get headaches in a pill-free break. So that we hear a lot, or people say, oh, I had a headache on a pill. And then it's just checking when does it actually happen? Because for a lot of women, it will not happen when they take the pill. It will happen when they have a pill-free break. And that is just a normal reaction of the body, because when estrogen level changes, goes up, down, or goes up or down, the headache can happen. So these women who get headaches in pill-free breaks, they may be better using continuous contraception where they don't have a break, and that prevents that variation. I think that's the review done then, and then you leave them on annual review. I mean, we always check what we do at the practice. We have a paper form where we ask them any new medical history, any change to smoking habits, any change to, and then we check the weight and blood pressure. We've got the machine in a waiting room, and then this gets reviewed by the trained member of staff, and decision whether to just continue for another year or that person needs to be brought back for an appointment comes from there. And I think just like as top two, really, just a quick one on the main things which we see in primary care, which, in relation to contraception. UK MEC are very good guidelines. I hope everybody is aware of a UK MEC that's issued by FSRH. You can find them on FSRH page, and they describe the risk level with different type of contraceptives. And I hope this will give you a bit more confidence what can be used in which situation. Very useful guide. So, okay.
I think
thank
I
you.
was going to say perfectly on time there, Dr. Craven. Perfect and much appreciated. And you've definitely clarified a lot of possible misconceptions which we hear about a lot. And that details around pill-free breaks, the generalized option of ensuring we get a good history. So I'm just going to clarify a couple of points that you just almost asked. I didn't want to stop you. You were quite passionate as you were just talking through that. But what the community pharmacists will do is they will also do an ongoing supplies will be obviously for a year. Yeah, but new initiation will be 3 months. So as you suggested, it'll be a 3 months period. We also have the UK MEC calculator, which is a very, very useful tool, which also saves all clinicians time. That's a very useful tool to be using. And you talked about sexual health services, and that is part of the spec as well, where they have to be aware of their local signposting to sexual health clinics. But what we have had is we've had a series of questions already sent in, which is why I wanted to go into the Ask the Expert session. But before I go into the ones that we've already received, I would love to just open it up, just in case there's anybody who's listening to anything just now, still got any queries and clarification. So if anybody wishes to put their hand up before I go into any of the questions, I will just offer the opportunity now, if that's all right. So if anybody's got any questions, if you could raise your hands on the webinar, that'll be fab. Okay, no problem.
Can I just say, with regards to the patch, Evra patch, that's the only patch we've got, contraceptive patch and vaginal ring. Do people issue? Is this something which is issued from community pharmacy or not?
So we currently, Dr. Craven, are restricted to oral contraception only. The progesterone, and therefore anything additional. Although there is a question which links to what you just said, which I'll come to shortly as well and ask you that question. But we do have to have a conversation around long-acting. Every consultation we have to emphasize the importance of LARC, and of course that could be any option. So all options can be considered in that conversation that community pharmacy has to have, but our options of supply are progesterone and contraception at this combined at this stage. What I will do, if we can, is I'll just emphasize, please utilize the chat function. If you don't want to raise your hand or come on live, please utilize the chat function. We'll keep an eye on that. But in the meantime, I will kickstart the Ask the Expert, if that's okay. On the questions we have already received. So we've tried to put them in some sort of order where I could, but we continue to receive them right up until the start of the webinar. So the first one we have, now I said we have 357 community pharmacies signed up, a multitude of different sort of pharmacists and clinicians and also technicians in the future. But the first question we have is, we obviously have, is about building confidence. That getting over that first consultation, that's what we really need to achieve with a lot of the pharmacists, perhaps is their first time. So as an experienced clinician, what advice would you have for those clinicians on their first consultation? What advice would you have for them?
I think the main thing is just to listen to your patient. That's to me, I think, and that never fails. So if you just let them say, and because people often, especially now with access to, information online, people will come with quite a, they already have researched their options, or most have researched their options. So it's not like it used to be that they came and they actually wanted just our opinion. They already looked at things. So just listening to them and just asking, that menstrual history is just super important. So and yeah. And be compassionate as well. There's different situations people come about contraception, and some are in situations when perhaps, we are in all sorts of situations, and it's very sensitive, and taking that intimate history is hard, and I think it's hard for everybody, and sometimes it's culturally more hard than some cultures than others, and cross culture, isn't it? But I think it's very important, just knowing, and especially that's super important with the younger ones. So always ask these questions, and just, because we are a safeguard for some of these women and girls.
Fantastic.
Yeah, and because community pharmacy will be a place where people will most, they trust. They will come recurrently probably, and for various things. So you probably will have some intel about a given person, and that if you feel they may be at risk of, if based on previous encounters your intuition is telling you they're at risk, just flag this up or discuss it with someone, or flag it up appropriately. So
That is
yeah.
fun. Thank you very much for that. It's just about building that confidence. Get started, ladies now are more aware. So start that initiation and listen. So I'm just going to flip from my listening to the sort of chat function. We've had a couple of questions come through live. So I'm just going to kick off with the first one. So the first question is, desogestrel, is it suitable for a 51-year-old if they have hypertension?
Yes, it is. So desogestrel is fine, but a progestogen only contraceptive. I think, she's obviously in the midst of menopause at that age, you would think. So you may be thinking that she could have signposting her for, discussion about that. And she could have then options, which are combined options for a contraception and managing their menopausal symptoms. And SLINT, drospirenone, plays really good role here for these age ladies, and especially if she has hypertension, because SLINT is that bit safer with CBD, but probably the safest at the moment, one of the safer contraceptive progestogens with regards to CBD. So that's drospirenone.
Thank you. So I've got a little update on that for you then. Good news. Currently, drospirenone is not included in our PGDs, but the good news is from October onwards, October 29th, they have and are going to include drospirenone. So all the items you've suggested today is going to be perfect to refresh the guys as drospirenone comes on. So I'm very, very pleased about that. It was a good option. And I'm going to continue with the questions, and we'll try and keep a bit shorter with the answers, try and squeeze in as many as we can. So the next one is, will we be able to supply any combined contraception given they meet the criteria? And I think the main reason for this, they've highlighted, is no restrictions on brand. It might be one that I answer here, possibly, because this is linked to the Lancashire and South Cumbria formulary. And that's what we need to go off. Within our patch, we have to go off the formula. And I'm very pleased to say, with discussions with the Men's Optimization and Chief Pharmacist Andrew, they have actually agreed that all criteria of combined are actually classified as green. So they can be supported. Of course, all community pharmacies still have to go off the PGD on the appendices. But what we need to do is make sure we do the best for the woman in question. But that being said, there is a little proviso. Dr. Craven covered that before. Is price would play a part. So if it's a case of 3 different brands impacting the same level with the same side effect profiling, if you like, then we have to go with the most cost effective for the NHS. Hopefully that answers that for you. And I'm going to flip again to the other questions we previously had. So this one is around the combined oral contraception. What they've said is, what are the main reasons for having different tailored regimes, and how do they benefit? each woman. So just I know
Okay.
you have covered it, but just as a brief brief
No,
overview.
I'm sure it's good to clarify that. So yeah, so the old-fashioned regime, and that's the only regime we used to have for a very long time, was about 21/7 on combined and continuous on progesterone only. And the reason why the extended regimes, so 24/4, were introduced, it was for usually just to one, improve compliance potentially, because they always come with the placebo pills, but mainly to control bleeding better. So extended regimes tend to work better for people with heavy bleeding, and certainly Zoeli, that's one of the pills which I use quite a lot, and Clara, which I use for very heavy bleeders and younger ones and possible endometriosis. They do respond quite well. It's certainly worth trying. And also with extended regimes, when obviously you can just, again, you don't have to use the 4, you can go active, if bleeding is a problem. See on a review, if a bleeding is still a problem, then you can try that and just see how that works for a person.
That is fantastic. Very good. Thank you. And if there's any counter questions, ladies and gents, on the webinar, just please, again, continue to put anything in the chat and we will just flip between the two. So the next one we have is a progesterone one. I think, again, you may have covered this, but the question was, why would anyone prescribe the norethisterone and levonorgestrel instead of desogestrel nowadays? They've just asked a general question, why would anyone actually do that? So I thought I'll put it to yourself.
Oh, it's very cheap, isn't it? So it's very, very, very historically well known by a lot of people. So it's in very many contraceptive products, because historically it was in medroxy and norethisterone was probably most of them. So if people are used to it, so it could be the habits of a prescriber, but we know that they control bleeding well. And sometimes, so even though we know they perhaps not great for other points of view, and especially acne, excessive hair, they are being looked at, this type of progesterones, all the progesterones, for a risk of breast cancer. A little bit more, because previously we thought, it's just estrogen dependent, but we know now that breast cancer, estrogen only HRT, for example, doesn't increase the risk of breast cancer. Combined one does. So we're now looking much closer. Generally, the research is looking much closer at progestogens in products, and we know that medroxyprogesterone, like in Depo-Provera, so that's the depot injections, they probably not the best, and like I say, it's that androgenic effect. But then again, if you got somebody with low libido, like I say, they could actually be quite positive to them. So it's just balancing, isn't it? So it's looking at the history and perhaps being upfront with a patient and saying, well, and I think patients do appreciate honesty. So, and I always say, we may not find, same with HRT, we may not find the perfect choice for you straight away. And this may not be possible because, your own hormone work with exogenic hormones, and how they're going to gel, there is some element of unpredictability there. But I think, that's why we do the reviews, isn't it? And just checking in with patients.
Yeah, and I think there's something else I think you mentioned earlier, which is quite important to cover. And we get this regular from queries from query pharmacists as well as they begin the sort of service. Is you've also got to give it time. Women might just, that's why it's a supply of 3 months. It's yes, we can certainly change that, but you have to allow a little bit of time for the supply.
Yeah, because people again are quite impatient, aren't they? Especially younger people. They sort of. Yeah, it needs to happen quick, doesn't it? So, and I think, saying, but also being again upfront and saying, oh, well, you may get breast tenderness in the first 3 months. You may feel a little bit sickly, but, your hormone level is changing. May you get headache? Yes, you may get a little bit of headache. It should all pass. Or may you get irregular bleeding? Yes, you may get irregular bleeding in the first 3 months. It is all possible. But as long as you're showing the pattern which is settling down, and again, with the bleeding, the important thing is if the bleeding is not settling down, it's always worth reminding people to get checked for chlamydia and, STI, just make sure there is nothing else. Or get checked with a GP, especially if it's a postcoital bleeding, because that could be completely different reason for it. So, just being vigilant to, is this just within hormonal dysregulation, or is this seem like something a bit out of ordinary, in which case, the signpost needs to be done then?
We're going to try and squeeze in a few more, we'll shorten the summary if we need to. We can always send the comms out to contractors.
The GLP-1, Sarah put one about GLP-1, and this is really important. So obviously, you guys, a lot of pharmacists do prescribe GLP-1s for obesity. A lot of people take them in and out, on and off, for Christmas, before weddings, and all that type of thing. And they do affect absorption. And I think, we've got this problem with all the drugs. I always say it's not just contraception, but obviously contraception may mean unwanted pregnancy if GLP-1 decreased the effectiveness. And I would really strongly push them when they're on GLP-1s, just go. I mean, I'm surprised you can't prescribe Evrapatch, because Evrapatch isn't a lark, but it is what it is. But Evrapatch would be one way around it. But really, other to that, I would just be signposting for Nexpanons and coils, people who so especially if they're coming with you and they're on Mounjaro, but also just checking in a history. So thank you, Sarah, for that. Checking, are you taking GLP-1?
That's fantastic. I was actually going to come to Sarah with that one later, but no problem. Thanks for covering. So again, we'll probably just continue. It is a recorded session, if that is okay, just to squeeze in a few more questions, because we had a couple, a few come through around the emergency contraception as well. So I thought, let's try and squeeze in a couple of those, perhaps, to get rid of some misconception. The first one is emergency contraception, uniprostal, is it more effective than levonorgestrel when linked to weight or BMI?
Is it more effective than
when it's linked to someone with a high BMI or weight, over a certain category?
I think Ella1, isn't it? That's the 5-day pill. It's obviously meant to be the more effective option, and especially if there is any hesitancy around timing of intercourse, and being a higher dose, it is likely to be more effective. But I don't have an exact detail. I think I would probably go for a postcoital 3-day one, only probably when they're within 24 hours. After that, I'll probably err on side of caution and go for Ella1. But
and the next question is
and then you've got IUD, of course. So again, if you worry about these signposts for IUD, so you can do I get IUD done 5 days postcoitally as well, and then that gives them really good protection.
That is always an option that all our pharmacists discuss when they're having the consultation. It's always an offer that forms part of the local sort of commission services. But the other one again is linked. So you can see it's about access and the future prevention as well. When we've captured, if you like, the woman coming in for emergency contraception. The next question is linked to that. It was, what is the advice for a pharmacist when initiating desogestrel as soon as the lady is coming in for, say, Levenel or uniprostal? What's the advice? So have the consultation on emergency contraception, but then also have the consultation about initiation of desogestrel. Is there any specific criteria they should be just remembering or keeping sight of?
Well, with after emergency contraception, it usually will be a good idea that they sort of make sure, in case the emergency contraception failed, that they get normal cycle. Now, this is not always possible, because some women just don't get normal, what we call normal cycle or regular cycle, and they may not get cycle for a bit. So it's I would say doing pregnancy tests, checking for pregnancy about 2 weeks after emergency contraception have been used, and starting from there. Although desogestrel, even if somebody gets pregnant when taking desogestrel, so you could argue you could start desogestrel straight away, but still do pregnancy test just to be on a safe side, as desogestrel it's not going to interfere that much with pregnancy either way.
That is fantastic. Could I just say a huge thank you? I think we've just probably just got to the end of the hour. We've just gone slightly over. Apologies on that. So the final few bits from me, so if you like, to our guest speakers as well, to Sarah and Dr. Craven, could I just say a huge thank you. It's the first time we sort of trialed this lunchtime ready across CPLSC for our contractors and teams, because again, we'll always record the session. It allows people to be in their pharmacies, supporting their patients and jump on as and when they sort of can. And it just gives them that work-life balance towards the evening. A couple of other final bits from myself, just as a reminder. Again, we'll send these details out. But of course, we have got the good news. Emergency contraception, ladies and gents, will now be included in the National Contraception Service from the 29th of October. That's the current provisional date. Again, there'll still be one final proviso, confirmation from NHSE closer to the 29th, but that is the current agreement. The spec and the details adjustments are already available on the NHS-BSA website for you to get accustomed to and review. But of course, we've been doing emergency contraception for a long time. The only added caveat to this is, in key locations, it'll be the same across the board. Yeah, Sarah touched on this. You'll have access to levonorgestrel and also ulipristal. Both will be an option. So suddenly we covered that issue around the third, fourth, and fifth day. So that'll be very, very popular, I believe, and very good and accessible. The other big skill mix indication and adjustment will be the pharmacy technicians. They'll also be able to support and do the consultations across the pharmacies to again free up the pharmacists for other services. And the biggest one we've covered.
Sorry, is it just for emergency contraception from pharmacy technicians?
That will be all the contraception service.
Okay.
So it'll be included. So the advantage of this is, and the final bit from me is the addition of drospirenone, which we've talked about and we've covered earlier. So some big changes coming on board. And I'll apologies, we've just gone slightly over. They'll have to.
And please remember, Yasmin has got drospirenone. So we already got that drospirenone you can prescribe Yasmin, I think, and that has got in a combined form drospirenone. So
yes, there's several options that are inclusive, and they're within the PGD, and the latest adjustments will be included in there. So I will stop on there if that is okay. Just a few minutes over, so apologies, dear contractors and teams. Again, it'll be a recorded session. We'll put it on our YouTube channel at some point in the near future. But again, a massive thank you from me to everyone and to the guest speakers. And we'll let you continue with your day. Much appreciated. Thank you very much, everyone. Take care. Bye now.
Thank you for inviting us. Bye.